Hello, welcome to this presentation by FERNE, the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled The Evaluation of Emergency Department Dizziness Patients, New Concepts. My name is Edward Sloan. I am currently Medical Director of the Physician Assistant Studies Program at Dominican University. I have most recently been an attending physician at Carle Foundation Hospital, and I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. Support for the development of this lecture was provided by EB Medicine. I am currently President and Board Chair of FERNE. The content for this lecture comes in large part by the monograph titled The Timing and Triggers Approach to the Patient with Acute Dizziness by Jonathan Edlow. It was published in Emergency Medicine Practice by EB Medicine, December 2019. Other parts of this educational lecture and the complete lecture are available at the FERNE.org website or on our YouTube FERNE.org channel. Also available is the June 2020 podcast, which was presented to participants in 46 countries, as well as a CME option on the EB Medicine website at ebmedicine.net, as well as at the specific website address noted below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. The next part we are going to do is Acute Vestibular Syndrome Bedside Diagnostic Testing. I include this as a separate part of this lecture because it's important to know that there are 5 different tests that you can do to make sure to be able to exclude posterior stroke in patients who present with an acute vestibular syndrome. I have a red rectangle around these 5 exam findings on the clinical pathway that are listed, because if any of these 5 is positive, you need to consider a stroke diagnosis for the acute vestibular syndrome. Now, of course, this is the most important thing we do as emergency care providers in the emergency department. Why? We first need to rule out life threats, and posterior circulation stroke is an important life threat. I've known colleagues who have had cases of young patients who present with dizziness who have progressed within the first 24 to 48 hours to posterior circulation stroke symptoms, and this can be catastrophic, especially if you have posterior cerebellar swelling in a fixed space that requires operative intervention, and it can often cause catastrophic outcomes. So this part of this lecture that includes the 5 exams findings that we need to exclude is an important part of what we do in this dizziness evaluation. Remember, 3 diagnostic strata, 6 diagnoses, 1 of them is posterior stroke, and these 5 findings, or the absence thereof, will allow us to exclude posterior stroke. So, acute vestibular syndrome posterior stroke findings. We are looking for stroke signs on our exam. 5 tests are performed. If any specific findings are noted, then a stroke must be considered. That's important because if you're considering posterior stroke, you should contact the stroke team even if it doesn't appear as though TPA is indicated for IV use in the emergency department. So, what are these findings? Abnormal nystagmus, vertical skew deviation, not a positive hit test, stroke findings specifically, or ataxia. All of these would suggest a central etiology and a possible posterior circulation stroke. What are the specific stroke findings that I just stated? I'll say them again because these 5 are listed in the monograph, but it is important to know these, and you can put this in the electronic medical record. Central pattern or bad nystagmus in the setting of acute vestibular syndrome. Skew deviation or movement of one eye up vertically with a vertical correction when you uncover one eye and expose the other. The absence of a unilateral corrective saccade or movement to the center on HIT exam is a finding that suggests posterior circulation stroke. CNS signs on a neurological exam, such as arm dysmetry or clumsiness, would suggest a posterior stroke. And anytime a patient is unable to sit or walk unassisted, you must consider a posterior stroke, even in the setting of acute dizziness. That is to say, you might assume that dizziness and nystagmus will cause all patients to have ataxia. This is not true. Patients with peripheral vestibular cause of dizziness should have normal truncal function and normal gait, even if dizzy. And my point is this: if a patient cannot walk, you need to consider this gait ataxia as a possible central etiology and a posterior circulation stroke. So in table 2 in the monograph, I've put a red triangle or a red rectangle around the exam component and what is considered peripheral, and next slide, what is considered central. You need to take a look at this because it's important to know which are those that suggest a posterior circulation stroke etiology and what needs to be excluded, in other words, to be able to say that it is a peripheral etiology. We're now going to look at the 5 different exam findings and distinguish those findings which suggest a peripheral versus a central etiology. So, acute vestibular syndrome, remember all the abnormal nystagmus findings are of concern in acute vestibular syndrome, even though they might occur in BPPV, which is peripheral. So let's stick to the acute vestibular syndrome, nystagmus. What are things that would suggest a peripheral etiology? Horizontal nystagmus with stimulation and a fixed horizontal movement, only fast to one side, regardless of whether gaze goes to one side or the other. So peripheral is considered as the possible etiology when it's horizontal nystagmus with stimulation and a fixed horizontal fast movement. That is, fast correction in one direction, suggesting one peripheral side with illness. What AVS nystagmus findings suggest a central etiology? Horizontal nystagmus that occurs without any gaze to one side or the other, that occurs just on its own, with the patient looking forward, this would suggest a central etiology. Vertical nystagmus, torsional or rotatory nystagmus, and or directional changing horizontal fast movement. That is, gaze to the left, quick right. Gaze to the right, quick left. All of these suggest a possible central etiology for the dizziness as we discussed in our nystagmus section. Now, what is the test of skew? You cover one eye, then uncover the other alternately. Now, when you do this, if there's a peripheral etiology to the dizziness, there's no vertical skew deviation. The pupil won't be skewed one way or the other on a vertical axis. So when there's no vertical correction with one eye then the other being exposed, this suggests a peripheral etiology. If, however, that when you uncover one eye and then the other, the pupils appear to be offset in a vertical axis and they need to correct, this would suggest a central etiology. So vertical correction as the eye is uncovered to get both pupils to be aligned on the vertical axis, this would suggest a central etiology. This is similar to having vertical nystagmus where your eye is going up and down abnormally, which is a bad finding in acute vestibular syndrome. The head impulse test. Now, this test I've identified on this slide in red is only verified to be useful in patients with nystagmus. That is, the rotatory feeling and some nystagmus observed on physical exam. And what we're doing is looking for some asymmetry in the vestibular response. So what do? You hold the head 15 degrees to each side, and then you move it quickly to the center. So left, center, right, center. If there's a peripheral etiology, that is, one peripheral vestibular system or the other is diseased, faltering, failing, if that's the case, when you move the head to one side or the other, there will be a corrective saccade. For example, I move the head to the left and then move it centrally. The eyes will tend to run a little past where they're supposed to and have a quick saccade or movement right back to the center in order to get the eyes and pupils in the center of the head. That would suggest that there is some illness on the right side that caused the eyes to drift in an additional direction with movement from the left to the center. If the left side is diseased, when you move the head to the right and to the center, the eyes will drift to the left because the left side is abnormal or diseased with neuritis or labyrinthitis. So what I'm saying is this. If you are considering a peripheral etiology, there should be a unilateral fast saccade to the center seen with eye movement suggesting a vestibular problem. In other words, having a fast saccade with movement to the center from one side or the other. If you observe a fast saccade on one side or the other, this is a good finding. It is a positive finding, and a positive finding suggests a peripheral etiology, suggesting that one side or the other in your vestibular system is failing. What would suggest a central etiology? If when you move the head from the side centrally, from both sides, and there is no corrective saccade on one side or the other, this suggests that there is no peripheral or labyrinthine abnormality and that the problem could be a central problem. So again, if there's no unilateral correcting saccade on one side or the other, then you must consider either it's no posterior stroke or a possible posterior stroke. So figure 5 on page 12 of the monograph shows you pictures of this HIT test. And it shows how the eyes follow the rotation to the disease side with a correcting saccade to the center. So if your right side is sick, move from left to center, the eyes will go an additional movement toward the right sick vestibular side and then recorrect. If there's a left side that's sick, move from the right to the center, the eyes will lag and go further to the left and have a corrective saccade to the center. So a unilateral compensatory saccade suggests a peripheral vestibular etiology of the dizziness. If there is no compensatory saccade bilaterally, no quick saccade on either side, no lag, no suggestion of a diseased vestibular syndrome system on one side or the other, and your eyes are correcting automatically on their own, this suggests that the vestibular system is working normally, and then you must think a possible central etiology, such as a posterior ischemic event. So, head impulse test language in our electronic medical record. It's only performed in patients with nystagmus. It's performed in patients with acute vestibular syndrome to exclude stroke, posterior system stroke. In normal patients, there will be no correcting fast saccade, and in those with a possible central etiology, such as posterior ischemic stroke, there's no correcting fast saccade. So, if there's a unilateral corrective saccade to the center with a turn from one side to the other or the other to the center, this suggests a vestibular etiology with a unilaterally sick or diseased side. So a unilateral eye saccade with the HIT test in patients with acute vestibular syndrome and evidence of nystagmus, a unilateral eye saccade is correct. It's good. It suggests one sick vestibular side, and then it suggests that there's a peripheral diagnosis or etiology of the dizziness. No saccade on one side or the other suggests that there isn't a peripheral cause on one side or the other, and that you need to seek a central etiology or a posterior ischemic event. Next, we're going to talk about the fourth thing we must consider to exclude posterior stroke, and that is evidence of specific neurological exam findings that suggest a posterior event. So, if it's a peripheral etiology, there should be no findings. There should be no cranial nerve, brainstem, or cerebellar findings. What would suggest a central etiology or stroke findings? Limb ataxia, weakness or clumsiness of the arms or legs, dysarthria, hearing loss, dim vision, pain or temperature sensory loss, not light touch, but pain or temperature sensory loss, and or diplopia, ptosis, or anisocoria. All of these might be findings that would suggest a central etiology or posterior ischemic event as the cause of the dizziness. The fifth and last posterior stroke finding, which must be included, really addresses truncal ataxia and the ability to have a normal non-ataxic gait. If it's a peripheral etiology to the dizziness, there should be no findings. The patient should be able to sit in the cart or chair without having to hold on, and the patient should be able to walk without a wide base ataxic gait. A central etiology is suggested if the patient is unable to sit without holding on or unable to walk assisted. That is to say, every dizzy patient has to be able to walk out of the emergency department. If they remain so dizzy that they have to be put in a wheelchair to get to their car because they can't walk, that patient needs to be admitted and observed for suspected central etiology or posterior circulation ischemia etiology of the dizziness. So let's do another question, dizziness and nystagmus. In patients with acute vestibular syndrome, nystagmus findings that suggest a central cause include all of the following except. So which ones are true? Unilateral or unidirectional horizontal nystagmus, B, torsional nystagmus, C, vertical nystagmus, D, direction changing horizontal nystagmus, which is gaze evoked. And we know the answer, which one is false, that is not a sign or likely central cause suggestion. That is unilateral or unidirectional horizontal nystagmus. The others, torsional, vertical, and direction changing nystagmus, all suggest a central etiology, and that's seen here. Answer A is the one that is not correct or not a central cause, and that's from page 10 of the monograph. In conclusion, the ATTEST system for the evaluation of the dizzy patient includes the following: A, associated symptoms, T, timing and triggers, ES, examination signs, and T, confirmatory testing. ATTEST. When evaluating an ED patient with dizziness, please consider the following. Using the ATTEST system for evaluating ED dizzy patients, those patients with acute, severe, continuous symptoms should be considered to have acute vestibular syndrome. Patients who have intermittent symptoms or non-continuous symptoms at the time of evaluation are noted to either have triggered or spontaneous episodes of dizziness and vertigo. Topping the list of diagnoses using the ATTEST system are orthostasis, BPPV or benign paroxysmal positional vertigo, and posterior stroke. BPPV can be diagnosed with the Dix-Hallpike maneuver and can be treated with the Epley maneuver either in the emergency department or in follow-up. It is noted that you should evaluate patients with caution in the setting of the COVID-19 pandemic, as the COVID virus can cause neurological symptoms and or can complicate those neurological symptoms because of poor PO intake and dehydration, which can cause orthostasis. Electronic medical record templates and dot phrases can help to make the exam process more systematic and easily accomplished using the ATTEST system. When evaluating dizziness patients in the emergency department, the following is recommended. Understand that the dizziness pathologies using the ATTEST system fall into 3 diagnostic strata and basically involve 6 diagnoses and 3 specific treatments for those diagnoses. Also recommended is that you study the Nystagmus findings, significance, and BPPV maneuvers, Hall, Pike, and Epley, online and in the monograph from which this lecture was obtained. Also, create EMR templates and dot phrases to exclude posterior stroke findings in your dizzy patients in the emergency department. Explain the etiology of the dizziness, including the diagnosis and treatment, and provide appropriate referral for patients with dizziness, explaining to them symptoms which should cause them to come back to the emergency department for repeat evaluation. Lastly, utilize caution when evaluating dizziness patients in the emergency department in the setting of COVID-19, as this virus has both neurological complications and symptoms and can cause orthostasis due to decreased PO intake. If you have specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you to go to the fern.org website for more content related to this educational program and other content related to the care of patients who present to the emergency department with acute illness and injury related to neurological emergencies. Thank you for your participation in this FERNE educational program.